Radiation has sufficient energy to cause the ejection of electrons from atoms. Loss of electrons results in the ionization of atoms and engenders subsequent biological effects. Benefits must outweigh the risks of any diagnostic study using ionizing radiation. Ionizing radiation can either be natural or man-made. Human-made radiation occurs from several sources. Medical and dental X-ray examinations make up the largest portion of human-made radiation exposure. Natural background radiation sources are terrestrial radiation such as radon and thoron, cosmic radiation such as solar and galactic, and internal radiation from radioactive atoms, also called radionuclides. Man-made radiation sources are consumer products containing radioactive material, air travel, nuclear fuel for generation of power, atmospheric fallout from nuclear weapons testing, nuclear power plant accidents such as Chernobyl, and nuclear power plant accidents due to natural disasters. Radon and thoron natural background radiation accounts for 37% of total exposure. CT scans account for 24%, whereas fluoroscopy only contributes 5%. Nuclear medicine contributes 12%. Artificial sources of radiation accounted for 48% of the total collective EFD. Effective dose of the U.S. population as of 2006. Conditions necessary for X-ray production are 1. A source of electrons. 2. A means for setting them in high-speed motion. 3. A mechanism for decelerating them abruptly. In an X-ray tube, the cathode's filament is heated by the filament current, and milliampere, directly controls the temperature of this filament, which in turn determines the number of electrons produced through thermionic emission. In an X-ray tube, the potential difference is the electrical voltage between the cathode and anode. The kilovoltage peak is the maximum value of this potential difference applied during an exposure. The kVp determines the speed of electrons, their energy upon impact with the anode, and consequently, the maximum energy and penetrating power of the resulting X-ray beam, which controls the beam's quality. A suitable target material, usually a tungsten anode in a medical X-ray tube, is used to receive the impact of the high-speed electrons. Units of measurement. Coulombs per kilogram measures exposure in air and is not used to express absorbed dose to individuals. A measure of ionizations in air as a result of exposure to X-rays or gamma rays. Radiation absorbed dose is expressed as Gray, big G little y, which measures the amount of energy absorbed in any medium, defined as 100 ergs of energy absorbed in 1 gram of absorbing material. Equivalent dose accounts for different types of radiation and their biologic effects. Rem, little rem, has been replaced by the sievert, big S little v. 1 sievert equals 100 rems. It is expressed as the product of the absorbed dose and a radiation quality factor. Air kerma is a unit that measures energy transferred from radiation to a material. Kerma stands for kinetic energy released in matter. Air kerma is the total kinetic energy released in a unit mass of air or tissue and is measured in joules per kilogram, big J over kg. The becquerel measures the activity of a radioactive material, of a radionuclide. It is used in nuclear medicine and radiation therapy and is defined as 1 disintegration per second, abbreviated as DPS. 1 Curie, big C little I equals 3.7.7 times 10 to the 10th becquerel. Standards of exposure are regulated by the FDA and its Center for Devices and Radiological Health, the CDRH. Effective dose limit recommendations have been set to minimize the biologic risk to exposed persons. An individual's dose should be kept as low as reasonably achievable. The annual whole-body effective dose limit for the occupational worker is 50 msv little m, big S, little v. The dose for a pregnant occupational worker is 5 msv. There is no dose limit for patients. Their dose is dependent on the choices they and their physicians make. Dose-response relationship. Physicians use a risk versus benefit rationale when ordering ionizing radiation studies. The benefits of an exam must outweigh the potential risks from radiation exposure. Doses should be kept as low as possible, and no dose is considered totally permissible. In a graph of a dose-response curve, dose is an amount of radiation, tracked on the horizontal x-axis. Response is any effect of the radiation dose, tracked on the vertical y-axis. Linear plots are a straight line and sigmoidal plots are an S-shaped type curve. For threshold values, plotted as either a curve or straight line, there must be some minimum threshold to produce a response. These begin at 0 on the y-axis someplace to the right of the origin on the x-axis. Non-threshold curvy or straight lines begin at the origin, indicating that any effect leads to a response. There are biologic effects resulting from exposure to radiation. The two major parts of cells are the nucleus and the cytoplasm. The genetic material of a cell is contained in the nucleus. 80% of cell content is water. The two classes of human cells are somatic and genetic. There is a direct hit theory and indirect hit theory of cellular damage. Cells have different degrees of radiosensitivity. Cellular radiosensitivity is principally a result of the rate and duration of cellular mitosis according to the 1906 law of Bergoni and Tribando, but this law has been modified to take into account the time interval in the cell life cycle wherein the ionizing event occurred. Cells that are actively dividing, such as stem cells and those in the bone marrow or intestinal lining, are more susceptible to radiation damage. Immature, undifferentiated cells, like stem cells, are more sensitive to radiation than highly specialized cells. Examples of radiosensitive cells are lymphocytes, spermatogonia, erythroblasts, and intestinal crypt cells. Examples of radioresistant cells are mature, non-dividing cells like nerve cells and muscle cells. Interphase is the longest part of the cell cycle, during which the cell grows, performs its normal functions, and prepares for division. In the mitotic, or M-phase, cell division occurs. In prophase the chromosomes condense, the nuclear membrane breaks down, and the mitotic spindle begins to form. In metaphase the chromosomes align at the cell's center, forming the metaphase plate. In anaphase sister chromatids, identical copies, are pulled apart to opposite ends of the cell by shortening spindle fibers. In telophase the spindle breaks down, new nuclear envelopes form around each set of chromosomes, and chromosomes decondense. Cytokinesis is the final physical division of the cell's cytoplasm, creating two distinct daughter cells. An ICP mat sandwich. Somatic effects of radiation exposure are effects upon whatever body was irradiated. Genetic effects are effects upon future generations due to the irradiation of germ cells in previous generations. Potential results of radiation to a cell include cellular death, delayed mitosis, and an altered mitotic rate. Fortunately, most cells can recover from radiation damage, but incomplete cell repair can have harmful effects. Total body response to excessive radiation can result in acute radiation syndrome, IRS, and results in early or late effects. Late effects are cataractogenesis and carcinogenesis. IRS progresses through 4 distinct stages. 1 prodromal stage, in 0 to 2 days, causes nausea, vomiting, diarrhea, fatigue, and anorexia. 2 latent stage, in 2 to 20 days may manifest mild symptoms such as fatigue or nausea but is not readily discernible. 3 manifest illness stage, in 21 to 60 days, causes symptoms that vary depending on the dose of radiation and the organ systems affected. Examples of damage are hematopoietic syndrome, or bone marrow damage, low blood cell counts, bleeding, infections, gastrointestinal syndrome, or damage to the digestive tract, nausea, vomiting, diarrhea, dehydration, neurovascular syndrome, or damage to the brain and nervous system, seizures, coma, and even death. 4 recovery or death occurs beyond 60 days. Recovery is possible, but may take months or years. Death is a possible outcome, especially at high doses of radiation. Because cells contain a repair mechanism inherent in their biochemistry, repair enzymes, repair and recover can occur when cells are exposed to sublethal doses of ionizing radiation. After sublethal doses, surviving cells will be able to divide and thereby begin to repopulate in the irradiated organ. This process permits an organ that has sustained functional damage as a result of radiation exposure to regain some or most of its useful ability. Hematopoietic syndrome, or bone marrow syndrome, can result from exposure to from 1 to 10 grays. Gastrointestinal syndrome appears at a threshold dose of approximately 6 grays and peaks after a dose of 10 grays. Cerebrovascular syndrome, which affects the blood vessels in the brain, results from doses of 50 grays or more. The 3 cardinal rules of protection from radiation exposure are time, distance, and shielding. Dose can be minimized through X-ray beam restriction, image receptor speed, filtration, and optimum exposure technique selection. The use of patient shielding, flat contact shields, shadow shields, shaped, contour shields, and gonadal shields is essential in the practice of ALERA. Time considerations to protect patients are minimize the length of time they are in the primary beam. Consult technique charts and use shorter exposure times to avoid repeat exposures. During fluoroscopy, use less beam on time. Time considerations to protect technicians are during fluoroscopy, spend the least amount of time in the room that is practical. Distance considerations to protect patients are to maximize distance between the patient and the source of radiation. SID should be at least 40 inches, or 100 centimeters. Distance considerations to protect technicians are to increase the distance from the source of scatter, the patient, during fluoroscopic and mobile studies. Shielding considerations to protect patients are to collimate the beam to the area of interest only. Use gonadal shielding whenever possible. Provide a lead apron to the patient when extremities are being radiographed. Shielding considerations to protect technicians are to wear lead aprons and thyroid shields during fluoroscopic and mobile studies and to stand behind fixed or mobile barriers. Any occupational worker who is regularly exposed to ionizing radiation must be monitored to determine estimated exposure. Any worker who is likely to receive more than 1/10 of the recommended dose equivalent limit should be monitored. Field survey devices measure the presence and rate of exposure in real time. Personnel monitoring dosimeters are required. Monitors measure the quantity of radiation received on the basis of conditions in which the radiographer was placed. Exposure data is collected for a specified period of time. These are worn at the collar level and worn outside of lead apron. A device should face forward. Pregnant radiographers may have a second device worn at waist level and under the lead apron. The field of digital radiography underwent many changes between 70s and 90s. The digital computerization of CT and ultrasound, diagnostic medical sonography or DMS. The creation of electronic datasets is now applied to all imaging modalities. The visualization of anatomy in multiple planes. And computer manipulation of imaging data through sophisticated post-processing software. There are two types of digital radiography systems. Computed radiography, or CR, uses photostimulable imaging plates, PSPs. Digital radiography, or DR, which employs either direct conversion without a scintillator or indirect conversion with a scintillator. DR receptors are referred to as flat panel detectors, or panels. Healthcare reimbursements are set up to encourage DR at its lower dose. For digital image formation produces analog signals, a series of voltage fluctuations on a continuous waveform with infinite values between an upper and lower value. These must be converted to digital language. Analog to digital conversion is known as ADC. Digitization employs binary machine language, the two-symbol alphabet of 0 and 1. It is accomplished through the sampling analog voltage values measured at a chosen sampling frequency on the analog waveform. Each sampled piece is then computed and assigned a discrete analog value, a process called quantification. These values are then converted to a binary digit. 8 bits equals 1 byte. The receptor matrix is made up of pixels and voxels. Voxels pertain to the three-dimensional images of modalities such as MRI. Field of view is known as FOV. Spatial resolution, or image sharpness, is dependent on matrix size and how it relates to its resolution, upon how many pixels, or picture elements are present. It is measured in line pairs per millimeter. Voxels are the volume element. The overall dimensions of an image matrix is called field of view, or FOV. For two-dimensional digital radiography images, the FOV is determined by the image receptor. For modalities like CT and MRI, the FOV can be operator selected. Each pixel contains a bit depth. Bit depth determines number of assigned gray shades to pixel value. Greater bit depth yields a greater range of gray shades. Image file size is affected by pixel size, matrix, and bit depth. Point processing operations include adjusting the input image with the output image, application of the lookup table, or LUT, and windowing for contrast and brightness. Digital image quality. Regarding spatial resolution, as matrix size increases, pixel size decreases and spatial resolution increases. Regarding density resolution, as grayscale bit depth increases, density resolution increases. Contrast resolution. Low contrast resolution, or LCR, has the ability to represent small energy values in the dataset. CR and DR receptors have excellent low contrast resolution and a greater dynamic range. An exposure index, or EI, provides information about exposure to an image receptor. It represents acceptable ranges for the best image quality and is expressed as target exposure indicators, big E big I little t. EI is calculated using histogram values and pixel values of interest, PVOI midpoints. This system varies between vendors. ATC systems range between 300 and 1000. RAD techs are responsible for understanding and applying EI values, which assess image quality and denote Adler compliance. EI is usually indicated at the bottom right of an image plate and may be expressed as a sensitivity number, S number, exposure index, EI, or a log median exposure, big L little g big M values. The imaging process nearly the same for all modalities. Radiography, fluoroscopy, computed tomography, sonography, MR, radionuclide imaging, mammography, DXA, dual energy X-ray absorptiometry. There are 5 phases to the imaging process. Phase 1. Image acquisition. Phase 2. Image processing. Phase 3. Image archiving. Phase 4. Image display. Phase 5. Image analysis. Remember APADA, APADA, an Italian competitor to Prada. Acquiring. Processing. Archiving. Display. Analysis. Radiographers expected to uphold technical and ethical standards, satisfy diagnostic needs of the radiologist, supervisor, and patient, maintain standards of image quality and patient care, practice ALRA, and assess images critically for acceptability. What is the pyramid problem? Radiographers work with many variables including technical factor selection, subject density, contrast, pathology, and patient conditions, equipment functionality, image processing, and the interrelationship of these factors can result in endless potential problems. In a radiographer's scope of practice, medical diagnosis not permitted, but technical diagnosis required. A radiographer is a true professional expert at creating images and understands the technology behind image creation. When seeking diagnostic process improvement, remember that cues are not diagnosis. Be careful to separate observations from inferences, avoid jumping to conclusions at first cue, and to look for competing hypotheses. Criteria for acceptance limits and the graphing of acceptance limits. Striving for perfection. Factors affecting acceptance limit curves. Practical considerations. Exposure index numbers are a convenient and effective benchmark. Parties responsible for evaluating acceptance limits are radiographers, supervisors, radiologists, and other physicians. Extremely narrow acceptance limits can result in high repeat rates. Wide acceptance limits may result in high repeat rates. Furthermore, technologists can become careless and the quality measures of a department are placed at risk. A graph of acceptance limits fixes the limits of acceptable versus unacceptable radiographs. Width of acceptance limits affects repeat rates and quality measures of the patient experience. The y or vertical axis of this graph denotes quantity of procedures. The x or horizontal axis indicated underexposure to the left of the bell curve and overexposure to its right. Perfect diagnostic imaging occurs within the topmost region under the curve. Acceptability is bounded by symmetrical vertical limits to the left and right of perfection. The x-axis width of acceptance limits affects repeat rates and quality measures of patient experience. Corrections should strive for perfect images, not just acceptable images. One's competency is questioned when they are unable to correct repeated mistakes, so learn and apply the rules of image quality. If repeat radiographs are necessary, make changes large enough to cause a visible difference. Above all, be confident.